Contrast-Induced Nephropathy. There's only 9 papers here, so we can cover kind of what the issues are and as much as is known about this sort of thing fairly well. In some ways, contrast-induced nephropathy is sort of like hypertensive urgency. You know, it's what you think it is. So how do people define this? They say, well, if your creatinine goes up by more than 0.5 or more than 25% of its baseline, and you'd gotten some contrast, that's contrast-induced nephropathy. We know that the contrast that you get has an adverse effect on that measurement, okay? The real issue is not so much, I think, as far as I read this literature, whether you can measure, you know, 24 or 48 hours later the fact that the creatinine goes up, because it goes up in most people. And if it hits that magic number of 25% or 0.5, you say they had nephropathy. If it's not that, then you say they didn't. So that's sort of a what we call a disease-oriented measure. The real issue, I think, is how many actually go on to getting renal failure, because that's really the only thing that matters with this kind of thing. And so let's kind of look at how we can measure this. Al Sacchetti wrote a nice thing here because there's lots of things that are not in the abstracts that we have. But I think the first point that he makes is, can you predict their renal function from just the serum creatinine? Okay, how many here, when they get the printout of the lab, it comes back with a creatinine, they get the GFR next to it? Yeah, how many got that 5 years ago? No. So how do they get that? That's really, for those who don't get it, but hands up, where you just get the creatinine printout back, okay? So you have a tough job now because you got to figure out their creatinine clearance. Because I think the first set of articles here looks at, can you predict their renal function from the creatinine? And the answer is no. You can't do that. You can't predict clearance. There's a couple of different ways to measure clearance, and there's this formula that you use in here that they, you can actually get that. How many here have Hippocrates on a thing? It's right in Hippocrates, the calculation. What you want to do there, you just look up calc, and then look up creatinine clearance. There's a way of doing it on here. It's on Micromedics too, if you use that. Micromedics, there's a website here. You can get to it online to do it. And in PEPID, yeah. I mean, it's actually, you know, it's not a complicated formula. All it has in it is sex, age, ideal body weight, and creatinine. And then you just use the formula and multiply it out. And if you do that, say a female's 51 years old, she weighs 140 pounds, a creatinine of 1.2. Does that sound like a problem for getting a CT on that person with contrast? Well, their clearance is only 56. That's less than the number that they give of 60, putting them at risk for contrast-induced nephropathy. You know what, in the past, if I'd have looked at a creatinine of 1.2, say, it's a big deal. If that person is now 70 years old, creatinine clearance is almost 70, okay? Different numbers there. So I think what you have to do is be aware that just the creatinine alone doesn't do it, and that you need to actually calculate it out if you don't get that printed out. The thing that printout, though, how do they do that? Well, that's because they have a computerized information system, and they must put in something. So they can obviously get their age, and they can get their gender, and they can get their creatinine, but I don't know how they get ideal body weight in that. I mean, I know our information system doesn't capture that into the lab system, so they must have something where they just give a range for that kind of thing. But in any event, they actually, the real way you measure creatinine clearance, you know, back to sort of medical school days, is you collect urine for 24 hours, and you measure the creatinine in the urine and the serum and the volume and do a calculation based on that. Obviously, we're not going to do that. So Al has laid out some things here where they took patients and actually measured their creatinine clearance and said, if the old idea was if you had a creatinine less than 1.5, you were okay. Look at what the numbers here. The sensitivity for a GFR of less than 60, which is their magic number, if their creatinine is 1.5, is about 60%. So you're potentially in the danger zone there. All right. So that's first abstract. Is bicarbonate useful in preventing contrast-induced nephropathy? And I think the answer is maybe. The studies in here are fairly weak. The trouble I have with almost all of these is that they give such small doses of IV fluids. You know, most of these that talk about a protocol of IV fluids talk about 1 cc per kilogram per hour. For the average person, that's 70 cc's an hour. That's not even an ER dose. I mean, you know, we can't cut it back that much on things. So I was actually surprised by this. I had a woman where it was a worry about it, and I tried to find the hospitals or the radiology protocol for this kind of stuff. I had given her almost a liter of fluid, and then they said, no, you got to give them, you know, 70 cc's an hour for the next hour before we're going to do this study. And I said, well, geez, that's nothing. So in any event, they look at here giving patients just regular sodium chloride versus bicarb, and the incidence of contrast-induced nephropathy with just sodium chloride, 35%, 7% with bicarb, having hemodialysis, 10% with sodium chloride, 3% with bicarb. So I think there's some evidence, and the trouble with the study was that they lumped patients that either had a creatinine greater than 1.1 or a GFR less than 60. So were they the same in both groups? Because just having a creatinine greater than 1.1 doesn't mean you have a GFR less. I don't know why they didn't just go and calculate it. So it's sort of a little bit of a funny study. So you don't know that the groups are actually equal there. The next study looked at coronary angiography in patients with sodium bicarbonyl normal saline. They didn't really find much of a difference. And again, they gave this 210 cc's an hour was what I calculated. They had to give 3 milligrams per kilogram for 1 hour prior to the procedure. That's like 1 Diet Coke, as far as I can tell. You know, it's just small amounts of stuff for people who are getting angiography. So they say prophylactic hydration with sodium bicarb was not protective against development of contrast-induced nephropathy. I think my take on it is, yeah, tiny doses don't work. It'd be nice to see some real doses. You know, I think it's so funny that after the hypothermia stuff for patients after cardiac arrest who don't wake up, we give them, you know, 2,000 cc's of cold saline and don't think twice about it. And here, where somebody we're worried about their hydration status, we give them, you know, 1 can of Coke. I mean, it's really amazing how small they use. The other thing I didn't cover that Al went over in the first part here is before the title, Can Serum Creatinine Predict Renal Function? He talks about how you make an isotonic saline solution using 1.5 amps of bicarb to a liter of half normal saline, if you somehow have to do it. I think rather than, I think the point is to know that that can be done and say to pharmacy, do that or have it. I don't know that we're going to handle that, but that's what most people use in these kinds of things. So for the current role of sodium bicarb pre-procedural hydration, a meta-analysis, they would say that, yes, you can prevent contrast-induced nephropathy, but you can't prevent mortality or renal failure. So that's sort of a weak recommendation. Most others that look at the more go on to contrast-induced nephropathy, the more go on to renal failure. This finds that that's not quite the case. So how about N-acetylcysteine preventing contrast-induced nephropathy? There's some idea that this mediates the problem with the kidney. And so they do studies where they, again, almost all these sort of studies, these studies are kind of funny. They gave IV fluid, 1 cc per kilogram per hour, tiny dose, and then they gave them N-acetylcysteine before and after. So the problem for us translating this to emergency medicine is, for most of the ones we do, we don't have a before if they're going to get an IV, if they go to the cath lab, say for PCI, something like that. So in any event, they then also looked at another measure of renal function called cystatin. Has anybody ever heard of that before this? I had never heard it. It's some sort of marker of renal function, and they compared whether your creatinine went up or this marker of renal function went up after getting a procedure and getting either N-acetylcysteine or not. And what they said was these two markers didn't go the same direction. And so as I've said many, many times on a lot of the talks, what's the gold standard here? The gold standard for every other study on this is your creatinine going up. And nobody's looked at this other marker. So they basically concluded that it really doesn't work. N-acetylcysteine doesn't work. But every single number that they measured was better. Contrast-induced nephropathy, 6.5% in patients getting N-acetylcysteine, 11% in controls. Renal failure requiring dialysis in one control patient. So I think the reason they can't conclude this with more vigor is it's just a small study. So I actually read that as fairly positive for N-acetylcysteine. So if bicarb is iffy and N-acetylcysteine may or may not help, how about giving both? So here's a study where they looked at both. Again, it was a sort of a funny Spanish study. They took 111 patients without known end-stage renal failure who were going to get a PCI for coronary disease. They pre-treated them with some 12 hours, for 1 hour beforehand and 12 hours afterwards with saline. And then they gave them 2 doses of N-acetylcysteine beforehand, but everybody got it afterwards. So it's hard to, for something like that, it's hard to tease out the effect. But in any event, they found that the N-acetylcysteine worked. The numbers, though, are just astounding. They had the incidence of anuric renal failure in the patients that didn't get N-acetylcysteine was 1 in 7. 1 and 7 cases. So 7 out of 55. 13% of their patients going for PCI went into anuric renal failure. I just can't believe that. I mean, I know we don't know those numbers for our patients because we get them on the front end and don't see what happens 48 hours or a week later in terms of renal failure. But if those numbers are really correct, we don't have enough dialysis machines in our facility. So, yes, they found that it worked, but boy, the numbers were pretty strange. So the next one in here, 8, is an opinion piece. This is a nephrologist who says they've looked at all this data. And how do they say to handle this kind of thing? They say, number 1, don't do the study. If you can avoid it at all, don't use any study that needs IV contrast. This gets back, it's funny that Rick talked his whole talk about using contrast for abdominal CT for appendicitis and really focusing on oral contrast, where at least in our hospital, they get IV contrast with this, or IV and oral sometimes. So that's the bigger one. IV hydration with either normal saline or giving them some bicarb, minimal contrast, and then they said N-acetylcysteine or vitamin C to do that. I haven't seen anything on vitamin C. So this is their opinion about what we ought to do. And then 9 I only bring up because I think it's one of those what I call gamed studies. There's this idea that simvastatin, these agents that lower your cholesterol, they have many other properties, the so-called pleiotropic properties. And this is sort of, I interpret that as good for whatever ails you. And so it supposedly is going to do everything for everybody. So they wanted to see if in patients who are getting PCI, if you gave them simvastatin, if they had less contrast-induced nephropathy. Now, think again to the way I've mentioned this. How would you do your perfect study on that? Well, you'd take, first of all, you'd assure that they're not on it to begin with, okay, or another agent that's similar. And then you give some to one group, not give it to another group, randomize it so those groups are otherwise equivalent. And then how long would you measure their renal function for? You'd measure until sort of it either became normal or they developed renal failure enough to be on dialysis, a meaningful thing. Well, what did they do? They didn't not give it to some people. They gave 80 milligrams to some people and 20 to the others. So this is 80 better than 20? And their answer is yes, 80 is better than 20. However, they only followed patients for 48 hours. And what they said was in the 80 milligram group, their renal function had returned to baseline. Everybody bumped up their renal function for a little while. That happens every time you get contrast. Then it came back down. And so in the 80 milligram group, that had normalized for the most part by 48 hours. And in the 20 milligram group, it hadn't quite yet normalized. But then they never looked at it beyond that. So if it had normalized by 36 hours, what would be the big deal? Never looked at that. So this has the ring to me of trying to prove that you need to give it, because the conclusion is 80 is better than 20. We don't know if 80 is better than nothing in this. So it's sort of a funny study. Then there's the recommendations that the 2007 Society for Cardiovascular Angiography has. And all of those are pretty much just what I've covered here. Creatinine clearance is less than 60. Then you ought to think about either hydration, N-acetylcysteine, that kind of stuff. That's now, I think, I never was aware of this kind of stuff until maybe the last year or so. And the way that it gets handled is that our radiology department just handles it. They come and say to you, do you know that this number is this, and what are you going to do about it? So I think that's helped us. It's interesting here, they say avoid dehydration, and they say give at least a liter of normal saline starting 3 hours before. All the studies look at much less than that. And you can kind of read the rest of those. Use low volumes, use low ionic contrast. If they're at high risk, give them N-acetylcysteine before and after. And then stopping all the drugs that can also do this. You know, all the diabetics, you got to decide if they're on a drug or not. So I think we've kind of handled this well. Has anybody here had personal experience with somebody that got a contrast CT on, went into renal failure? Yeah. I think it's hard for us to know because we don't get follow-up. And I have one recent risk management case that the hospital asked me to look at that this was exactly the issue. And like a lot of these cases, it's not only one mistake. It's, you know, first of all, they shouldn't have ever had the study. And then they ignored the fact that one of this patient's risks for this was they had previous renal failure from contrast, that kind of stuff. So, but in any event, I think this is now something that's more on the horizon. I think we're going to, if their numbers are true in some of these things, this is a much bigger issue than radiation for the patients that we're seeing on things. And another reason to talk about doing non-contrast CTs if you're going to do a CT at all. All right, questions, comments, anything else? Yeah?
With a guy with a perforated ulcer, I wasn't involved in the case, but they gave contrast, then the creatinine came back as 500 in our units, which I think is 40 or 50 in your units, and it all went back to normal, so he was all right.
So he said one where it gets back to normal. Yeah, I think, you know, we must have gotten away with this a lot more than we think. You know, I think this is one of these things when you study it, you find a lot more things, but I think it can't be that bad as that, I said, 13% renal failure after PCI. You know, we wouldn't have enough dialysis units. Yeah?
Talked about making the bicarb solution, but with the reading reason you couldn't just give an amp of bicarb and then hang your liter of saline?
No. What he said is, why don't you just give him an amp of bicarb and give a liter of saline? I don't, you know, to me, there's no magic in these giving it so precise numbers, because half of the time some of it doesn't run in, and I don't think there's any science to the precision of this. Yeah?
I wanted to ask about the current evidence on stopping metformin after contrast.
Yeah, so the question is the current evidence on stopping metformin after contrast. I don't know that any of it's evidence-based. It's the theoretical. I haven't seen anything that says, in this group we stopped it, in this group we didn't stop it, but I know everybody gets advised to stop their metformin. You know, I don't know anything more than that.